from today.
Thank you. Yeah. Even.
No problem.
The learning and action objectives from today are focused on disclosure, and really we have recently rewritten the guidelines, the for disclosure of events. So we hope that by the end of this session, the residents will be able to understand how the disclosure guidelines have changed. Also, we want you to be able to identify the events that you need to disclose and the time frame for that disclosure. And then cite the information that needs to be documented in the chart. One of the biggest issues is you can disclose to a family, but if you don't document it in the chart, then there's, as far as legal is concerned, it never happened. So you have to make sure that you documented it in the chart. Next slide. And that basically there are no disclosures. And again, you can get CME credit for the faculty. And if you want credit, make sure that you've signed in for today. Next slide. So the CLEAR program the CLEAR program was started in 2012. And it's really focused not just on the residency programs and the institution that oversees those residency programs. It's also focused on the hospital, the medical center where you learn. And it is a partnership between those two institutions with a real focus on patient safety and healthcare quality. There have been visits here. The program started in 2012. There have been visits here in 2014, 2016, and 2018. And they come in and see how we're teaching, and what are the residents' experiences around patient safety and healthcare quality. There are 7 focus areas for the healthcare quality. I've already mentioned patient safety, and that's where disclosure fits. There's also an area around healthcare quality and healthcare disparities, and you'll be hearing more about that in the future. Another area is transitions of care, and the transitions of care has to do especially with how do you do your shift-to-shift handoffs and other handoffs when you're leaving a service and somebody else is coming on. So those transitions of care are critical. They're critical to patient safety, and they're critical for you to understand the patients you're taking care of. The other areas is a new area called teaming, and that again has to do with how you work with multidisciplinary teams. The other areas are wellness, which Dr. Mukta Panda, the other assistant dean, addresses and has a whole program on wellness. And then finally, supervision and professionalism. So at this point, I'm going to, well, no, I'll wait a minute. So disclosure and apology. And when something bad happens, so a patient is given the wrong medication, wrong site surgery, anything where there is a medical error is where we have to do disclosure and apology. Next slide. So as residents and fellows, but as residents, when you think about an event happens where there may be a medical error, what is your immediate response? What is your immediate responsibility? And obviously that's around the medical care for that patient, whether it's giving medication, CPR, rapid response team, talking and working with nursing or respiratory therapy. And then obviously following up what after the clinical response, what are the orders? Does that patient need to be transferred someplace? And then the ongoing clinical care. meanwhile, you also have to figure out how are you communicating with the family? How are you notifying them? But even before you notify the family and do any type of disclosure, obviously you want to let your attending know what is going on, what has happened, because he is the one who is ultimately responsible for that disclosure. And with that, I'll turn that over to Heather.
Hey everybody, my name is Heather Sveadas. Some of you I've worked with in the past on issues, but currently I'm the Director of Risk Management for Erlanger. And so Dr. Kohrt and I worked very closely together on recently revising the disclosure guideline that we're using here at Erlanger. In fact, that just went through Med-Exec Committee for approval in the past couple of weeks. So it's hot off the press, a few changes were made. And I want to kind of give you a background on why would I be involved in that process. I've been at Erlanger now for about 6.5 years in the role of risk manager and as an in-house attorney. And before that, I lived in the outside legal world representing doctors, nurses, area hospitals, one of which was Erlanger, in medical malpractice cases and defending them in malpractice cases. And so I came at it, when I came into Erlanger, it was a shock to my system a little bit to talk about disclosure of medical events because I was used to defending people in malpractice cases. And so the slide that you see now talks about the old model. Unfortunately, it kind of speaks to how old I am. But I came out of law school in 2002, and back then what our guidance as lawyers defending hospitals, doctors, and nurses is you do not say you're sorry, okay? You don't say you're sorry. When something bad happens, we don't talk to people about it. We certainly don't talk to the patient about how it happened, etc. And then we're going to defend that, right? So we're going to defend that case. So almost every adverse situation was postured for a lawsuit coming down the pipe, right? And that was the mode of our thinking. You certainly, when I say you would never say you're sorry, that guidance was even coming out from the malpractice insurance groups that insured our physicians and our hospitals and health systems and providers. So now fast forward to and let me back up before I say that, fast forwarding to the University of Michigan model. But what we were seeing happen, which led to the University of Michigan changing the way they did things and creating a paradigm for the rest of us in the industry, we were seeing that, you know, not only were physician-patient relationships broken, trust was eroded. The patient felt abandoned. They were kept in the dark. No one was talking to them because, my goodness, we don't want to disclose something that could hurt us in that lawsuit that might come down the pike. And so we saw that, and it was eating up doctors and providers as well. Both sides of that equation were suffering with the deny and defend approach to handling medical errors. So what happened is, can you go back? I'm sorry, can you go back one slide? I apologize. So patients ended up turning to, when their doctor or the person that they've put their health, their well-being, their trust in, right, to do something as big as pick anything. I mean, your primary care provider or a surgeon that is literally opening up your body and performing surgery on you. That requires a lot of trust. And when that trust relationship broke down, they didn't have anyone to turn to because we weren't talking to them at that point, right? So that's when they would turn to lawyers. So the question came up in the industry, is this the best way? Are we actually getting the benefit that we think we are from deny and defend? And so, okay, you go forward now on this slide. So again, we're seeing doctors who are broken. We're seeing physicians not talking to their patients. Patients feel abandoned. And they look at and they find that lawsuits are the only way. So go forward one more slide, please. But furthermore, and the biggest problem of all, setting lawsuits completely aside, is it chilled quality improvement in healthcare, right? So when we didn't have transparency around adverse events, when we didn't sit back and say, we're going to break this down and see where in our process we can improve things so that this thing that happened doesn't happen again, or at least we lessen the likelihood that it's going to happen again. Because we were taking the approach of don't talk to anyone, deny it, defend it at all costs, we were justifying substandard care. And it was hurting and hampering and stonewalling to a large degree quality improvement, which should be at the heart of healthcare, right? We're all humans. Healthcare is provided by humans. And so with humans come errors. It's part of it. It's part of being who we are. And so if you don't quality improve, you're not seeing progression down the path to get, hopefully mitigate the likelihood of recurrence of these errors. And of course, again, at the heart of it, you're eroding the patient-physician relationship. And it hurt not only the one patient-physician relationship that was at issue in a matter, but it was also hurting all the whole industry. Next slide, please. So, of course, why change? So, and I don't want to fully credit University of Michigan because I think others were also doing work at or around the same time, but University of Michigan is one of the primary examples of the industry changing around this, and they're the ones that create, help to promote the change in behavior. But they found that, honesty is paramount if we're going to improve safety in healthcare. And we were losing long-term improvement, all for short-term financial risk focus, right? So we're looking at, if we're honest right now and we're transparent with that patient, how is that going to hurt us if there's a lawsuit? Versus saying, wow, we really need to look at the whole forest and stop staring at the trees. We need to look and see what can we do to improve healthcare as a whole. What we know is that adverse outcomes are a reality of medical care. If you're involved in this field, you will see it. You will see it, you will see it. You will see unanticipated events happen. And according to the Institute of Medicine, if you just take one category of medical error, let's say medication error, for instance, studies show that almost 400,000 preventable drug-related injuries occur every year in hospitals. And that cost, talking about your short-term risk cost versus your long-term cost, just in financial terms, is estimated at $3.5 billion. So we were missing the forest for the trees. Next slide. So what we decided to do at Erlanger, and coming in-house, it was just eye-opening to me when I got here and Erlanger had moved on to that Michigan model of resolution, disclosure, and talking to patients and transparency. The priorities for the health system are, number one, open communication with patients. So when something bad happens, we talk about it. And we talk about it as soon as we reasonably can. Then number two, with the goal of reducing future injuries, and of course also from my standpoint, legal standpoint, reducing claims, because now we're going to report these incidents, we're going to investigate them, we're looking, what can we do to mitigate the likelihood of it happening again, and let's put those corrections in place. And then third, rather than waiting for an inevitable lawsuit to be filed, we start talking to patients earlier now. So when there's clear liability, meaning we provided care that was did not meet the standard of care, and there are quantifiable damages that result from that, often in the terms, most frequently of additional medical bills, lost wages, we go ahead and start looking at compensating the patients rather than forcing them to file a lawsuit to do it. And then fourth, and this is key, we don't pay on every claim that comes up, right? We are actually going to walk through that liability analysis to see whether it's warranted. Because there are cases where the patient thinks there's a bad outcome. There could be a bad outcome, but it has nothing to do with medical error. You guys have seen that. You see that every day where there's an unanticipated outcome, but it wasn't the result of medical error. And maybe your patient or their family thinks that it is, right? But in those situations, we don't just automatically pay out money. We will vigorously defend and support healthcare providers when there was not medical error that led to damages. Does that make sense? So recently, let me give you an example. We had a Erlanger and a provider had a birth injury case. Very expensive to try a birth injury case. You have to have a lot of very expensive experts in line to show that you met the standard of care. We tried that case in front of a jury to conclusion, despite multiple attempts from the plaintiff's counsel to settle the case. It would have been cheaper for us to settle the case than to try that case to conclusion and defend it. But we did, and we did it because it was the right thing to do. We won, we prevailed. The jury found that the defendants did not provide care that was below the standard of care. So ultimately we prevailed. But my point being, we don't just throw money at people, right? We actually do analyze and see whether there was liability resulting in damages. Next slide. So very important, very key, and at the heart of quality improvement is we need everyone out there on the front lines, nursing staff, physicians, residents, fellows, everyone who is out there touching patients, working in the health system, to report any event, okay? Any event, even if it's an event that did not cause any harm to a patient or even to a visitor at the facility, but could have. It could have, right? If you put that, raise your hand, put it into eSafe, which is Erlanger's non-punitive reporting system for safety events. Those events are all looked at and analyzed to see what can we do proactively, even if there wasn't harm, right? But propensity for harm. What can we do proactively to lessen the likelihood of a bad outcome later for someone else? Next slide. And why eSafe is so key, guys. You know, I have to go back to my outside litigation experience on this. I am not a fan of people shooting emails around with a lot of sensitive information in them. For a lot of reasons, mainly because I don't want it discovered if there is a lawsuit down the road, right? But eSafe is our incident reporting system. The whole purpose of it is to quality improve. And so back in 2011, the Tennessee legislature saw, you know, hey, we want to provide some legal protection for hospitals, physicians, all providers. There used to be just peer review. You guys are probably pretty, you know, you understand what peer review is, right? So we're looking at just what medical care doctors provide. But the Tennessee legislature said it's got to be bigger than that. We need quality improvement across the spectrum and with all levels of providers within healthcare. And to do that, they passed the Tennessee Patient Safety Quality Improvement Act. And what that did was it provided legal protection so that when you're engaging in a quality improvement activity that meets certain criteria, then that information gathered during that process and any subsequent measures you put in place to risk mitigate, that's not discoverable in a lawsuit. So if there is, let's take a wrong site surgery. Physician puts in, you know, hey, this happened today. I've had this call, by the way. Hey, this happened today. You know, we put it into eSafe. We're going to look at it. We're going to see what, you know, we're going to look at the timeout procedure. Did that work as it was supposed to? Did the sponge counts work as they were supposed to? And you just go on down the line for everything that you could possibly look at to see, was there a breakdown in process, right? But if there's a lawsuit that comes out of that wrong site surgery after the fact, the plaintiff's lawyers always will ask for your incident report. And 100% of the time, we say no. That's not discoverable in a subsequent lawsuit. It's protected, it's privileged, and we don't have to give it to you. And courts have upheld that because we've got that statutory privilege around it. So that's why I say when you do have an adverse event, please avoid emailing everyone about it. Put it into eSafe, pick up the phone, call risk management. That's where we're going to get quality improvement, and in a safe way you get quality improvement. And so what happens when you report something into eSafe? All of the reports are screened and reviewed, all of them. We look to see whether there needs to be action taken in each one of those, and actually trends are noted. So we can aggregate and see, do we have a problem area over here? Do we have, for instance, where are we seeing our high risk areas develop? Could it be that we have a lot of pressure injury situations with patients going on? Okay, let's look at what our wound care process is and protocol, and do we need to tighten that up in some way? So you're looking at for trends, and depending on the event, whether that event warrants us putting in place different policies, protocols, procedures, or just educating people on existing policies and protocols to lessen the likelihood of that event occurring again. Next slide.
So we've talked, Heather's talked about just what happens and the trends that are looked at. But from your standpoint, again, as the resident, events are entered into eSafe. And after you put that event into eSafe, you should receive a notification that the event has been entered into eSafe. That is one of the changes we've made within the last year to the system. The program director is also notified when you put something into eSafe, or if you are listed as one of the physicians in that eSafe event, the program director will be notified, as well as the nurse manager, administration, and quality. Next slide. So just so you guys have an understanding of what happens after that event goes in, I'm going to come back and talk about second victim support later on, but there is an initial review of that event. And then a decision is made of whether there needs to be further referral for that event. Does it need an ACA or an RCA, a root cause analysis? And then that RCA is scheduled within a 48-hour period. Pardon me 1 sec. Within that 48-hour period for that RCA. All of these lead to a process review and corrective action being developed. And then those lessons are shared systematically across the system and hardwired. As that all is happening, there's a new system, again, that we've worked on for the last year, and it's called File Tracker. And it actually allows people to go in, especially your program director, and to go in and look and say, okay, what's going on with that case that that resident was involved with, or what's going on with that case where that resident actually reported it, so you can find out what's going on. In the past, this has always been somewhat of a black box, and nobody really knew what was going on. So with this new system, it's much more transparent, and you receive information, and that information is upgraded on a regular basis until the case is closed. Once the case is closed, you will also receive another email, and the program director also will, that said the case has been closed. These are the recommendations, and then they can take that information back to you.
So now we've had an adverse event occur, and the question comes up, when do we disclose that? We disclose that now at Erlanger anytime an adverse event reaches the patient, regardless of whether it actually caused harm to the patient. That is a change in the policy, or I'm sorry, the guideline, the disclosure guideline that Dr. Kohrt and I just recently revised. That is a change. So our old policy read that only when an adverse event actually caused harm to the patient was disclosure mandatory. And up to that point, it was discretionary. And why change that language, right? So as the lawyer in me defending cases down the line, you know, I was the one that Dr. Kohrt actually had to kind of convince to make that change. But I hate to say it, but he was right. By the way, no, he was right. He was right. And the reason is because when you start cherry picking what you're telling your patient, you are starting to systematically and particularly when the organization endorses that approach, you're starting to systematically undermine that trust relationship between the physician and the patient. And again, there's a whole bigger picture than just what if there's a lawsuit, oh my goodness, there's a whole bigger picture that we need to look at. So what do patients want? Studies have shown, and there's been a lot of research in this area. You guys may have heard, I'm sure you probably have heard about this to some degree. Institute of Medicine tracks medical errors. As you can imagine, there are a whole lot, and there's been a lot of research around, well, when there's a medical error, what do patients want to see? They want full disclosure. They want full disclosure, and they want it soon. So when something bad happens, they want to know about it. They want to understand what actually happened. They want an expression of sympathy. We know that. And that can take different forms. We'll come back to that. And they want to know, what are you doing to prevent this from happening to someone else in the future? I will tell you, in the 6.5 years that I have been in the role of Director of Risk Management, rare is there a patient that I've worked with, even when it's through a lawyer, because sometimes there will be they've got a lawyer and we're still trying to reach resolution, right, and keep it out of a lawsuit. They almost always want to know, what are you going to do, Erlanger, to prevent this from happening again? That's a big, big deal. And it can be even the seemingly small things, right? So like, for instance, I had a discussion with a lady earlier this week whose mother passed away. And right before she did, she'd come to Erlanger, and the daughter said, you guys misplaced. She came in as a trauma through the ambulance, and you guys lost her mother-daughter ring. She said, I have the matching one, and now I don't have my mother's. And to her, that was heart-wrenching. It was particularly heart-wrenching at the time when her mother is actively passing away on hospice care. So her question to me at the end of our conversation is, what are you guys at Erlanger going to do to prevent this from happening to someone else? It can be something like that, seemingly less, right? It's not less important to those people, and that's not what I'm saying. But all the way up to the wrong site surgery, or the retained sponge, or something where there's a medication error even leading to death. They want to know what you're going to do to fix it for others, the sense of justice moving forward. Next slide. So we've talked about why disclose, but we disclose because we want to strengthen that patient-physician relationship, promote the trust that runs underneath it in order for it to work well. And we do know, from my standpoint, makes me very happy, and studies have shown that patients are less likely to pursue litigation if they believe that the provider honestly disclosed the event to them. And so, for instance, multiple studies have been done, and of course the results depend on who's doing the study, but it's been fairly consistent, and Michigan was one of them, and they believe that they've had a 50% reduction in legal costs and lawsuits as a result of implementing early resolution and transparency and disclosure around adverse events. That's huge, right? So what we know is that what we were doing before, we thought was helping us financially, but it was actually hurting us financially. Here at Erlanger, before we implemented early resolution, we had in the neighborhood of 80-ish cases, active cases at one time. Those have fallen dramatically. And of course, the trend in malpractice cases, it can go up at times, it can go down at times. But right now, we're around 30. And that we're technically in an uptrend right now in the industry. So if that tells you the difference between not disclosing and not working with people early on to resolve disputes versus actually doing it, there's a large discrepancy there. We also know that patients rate their experience much higher when they feel like there is an honest and transparent disclosure around any adverse events. But of course, providers, and I've been in these discussions too, you guys, they're not easy. I'm not going to pretend like they're easy. So what are the barriers to us disclosing these medical errors when they occur? We fear retribution, particularly if there's not training around how to actually do that. particularly if you've got a facility that doesn't have guidance around it. That can be very scary because you don't necessarily know exactly how to handle disclosure. But also, and this was really rampant, I think, in healthcare industry as a whole for a very long time, and we are really trying to move away from this. There was a culture of blame, of pointing fingers, of trying to almost pretend like the medical errors don't happen unless, you know, you're bad and you're at fault and we're pointing our finger at you. Well, what we know is that's not accurate, that humans do make errors, and that a lot of times our process for handling things could be fixed to minimize the likelihood of human error. So we're moving away from a culture of blame and a fear of lawsuits into a world of transparency, quality improvement, and instead of focusing on people and placing blame, looking at the process itself and how we can make the process work better for our medical providers so that they reduce the likelihood of committing an error. Next slide. So at Erlanger, we do have written policies and protocols to address how to manage adverse events. Okay, we have the disclosure guideline that Dr. Kohrt and I just worked on, and there's also an occurrence reporting policy that provides some guidance around how to manage adverse events. But what you really need to is a full commitment by providers at every level and the healthcare institution itself to help patients and families and staff, we'll talk about second victim as well, deal with these difficult situations when they arise. Again, we know they do. We know they do in very large numbers every year that cost a lot of money. And so what we want to do is reduce that, the likelihood of it happening again. But at the heart of reducing the likelihood of it happening again, we need people willing to step out, put things into e-safe, raise their hands when they see something went wrong or could go wrong. And to do that, you've got to create a just culture that focuses on system errors and it addresses the cause of human error instead of placing blame on people. Next slide. So Dr. Kohrt already talked about this and touched on it a little bit earlier, but the timing of disclosure, this is right out of Erlanger's policy. You want to disclose as soon as reasonably possible. Now there's every kind of factual scenario we could sit here and come up with for hours today, different factual scenarios that would maybe something happens and it takes longer to disclose, or we don't know there's an error right away and we find out much later that there's an error. There's every kind of factual situation you can think of. However, what you want to do is, taking into account the circumstances, disclose as reasonably as soon as reasonably possible. Within 24 to 48 hours of discovery of an event, if adequate information is available to make that disclosure. And we want to do that because particularly when patients are aware of it or they suspect an adverse event, the longer the time before disclosure, not only does it increase their anxiety, it decreases their trust in what you're telling them. The sooner you tell them what happened, the better off we are.
The only real caveat to that is basically, as a resident, if you're a first-year resident especially, you need to notify your senior resident or covering resident, and you need to make sure that the attending is notified. So he can indicate, again, depending on the severity, whether or not he's going to be involved in that disclosure. Our recommendation is that there is always an attending involved in the overall disclosure. But again, depending on time of day, seriousness of it, and the need to tell the family quickly, will determine who's going to be present at that time.
Right. And so once you've found your adverse event, you're getting ready to disclose, then the question becomes, where are you going to do that? So obviously, again, there are different situations. If you're down in the ED and the ED is bustling and there are a lot of people around, but it's something that you've got to talk about immediately, there are reasons why it's not always possible to do it this way. But when possible, you want meetings to be in person and at a place that the patient prefers to have it. in a private area, because again, we're worried about confidentiality. We want to maintain that confidentiality, and we also want to reduce the likelihood of interruption. When you're having an intense conversation, you don't want, number one, the provider who's having it to be distracted, right? And constantly checking their phone, or other people coming in and barging in and interrupting that process. You don't want that to happen. You also want the patient and or their family, depending on who you're talking to, you want them to be full focus. So if you're able to do it in a quiet place that's free from interruption, that's your optimum situation. Next slide. So this is the key, and I want you to always remember this. And I've seen many times where this didn't happen. But when you disclose an adverse event, you do not want to engage in any speculation, your opinion, and you certainly do not want to start blaming other people. Again, we're trying to promote a just culture and process improvement. And frankly, usually when you're having the beginning disclosure discussion, we'll come back to the stages of disclosure in just a moment. When you're starting to have that discussion, you don't have all the information in front of you, okay? So what I always tell people is just the facts, ma'am. Don't speculate. When you don't, they'll ask you, they'll say, why did this happen? There's a good chance in the early stages of an adverse event, you may not know why it happened. And you say, I don't know. Who did this? I'm not sure. We're not there to place blame. We're not there to start to get defensive. We're there to give them the facts of what occurred to the best of our ability at that time. And so, as I mentioned, there are stages of disclosure. Very broadly, that happens in 2 stages, okay? There's an initial disclosure, and then there's a post-analysis disclosure. Next slide. So the initial disclosure is the one that we want to happen as soon as reasonably possible after the event occurs. And you're going to have, usually it's going to be the attending physician, but not always. Like Dr. Kohrt said, there are going to be circumstances where something might have to be disclosed pretty quickly, okay? And so, but typically it's going to be, most often, a physician that's leading the discussion. Very frequently, I will have physicians call and say, hey, I want risk management to go and talk to this patient. And I'll have to say to them, yeah, now I know that's an uncomfortable conversation to have, but I hate to tell you, I'm not clinical. And so the last thing you want is a lawyer, we'll talk about why that looks bad in the first place, and not the physician that's involved with patient care talking to them about an adverse event. That's not what we want, right? We want somebody there that, number one, has been part of the care team, that can speak to that patient's particular clinical course, what happened, and then to answer their follow-up questions that they'll inevitably have clinically, right? Well, then what do we do now? Well, a physician's going to be able to say, well, here's our treatment course. Here's what we're going to do from a treatment standpoint if there's a modification in treatment because of the event, right? The physician's in a good position to do that. Risk management or administration is not. So only when there are just, very outlandish circumstances, or where the physician and patient trust is completely eroded already, and the patient says, I don't want to talk to that physician, then you call risk management. We come up with a plan on how to communicate, okay? But otherwise, it's typically going to be a physician that's disclosing. And you're going to focus in that initial disclosure discussion, you're going to focus on what is their current medical condition and what needs to happen now, but what needs to happen to mitigate the adverse event. So let me give you an example of a brilliant, and I'm not using anybody's identities, obviously, but there is a phenomenal physician who performed surgery on a patient, and it just so happened the patient is an attorney, and bless him. But anyway, he calls me and says, we left a sponge in this patient, and we're going to have to do a subsequent surgery. But do you know what he did? He immediately went to the patient as soon as they realized that. he went to the patient immediately, and had actually already talked to the patient before they ever called me. And he told the patient exactly what happened. They didn't exactly know why it happened. Sponge counts looked good, so they don't know. Initially, he didn't know what happened. But he said, hey, here's what happened. I don't know how that happened. We went back and checked our counts. Those were accurate. But setting that aside, here's what we're going to do. We're going to have to do another surgery to remove it. And then, of course, he'd reached out to me, and I said, yes, we'll go ahead and make sure they don't get billed for any of that, of course. And so then he was able to go back to the patient and say, okay, and obviously you would not be billed for any of this. And I am so sorry that this happened. And not only did the lawyer patient love this doctor and told this doctor just how great he was, and that was after this disclosure, but she never did anything with that. And by the way, retained foreign objects are a high area of liability from a malpractice standpoint. She didn't do anything with that. She couldn't, she didn't. She loved her doctor, and she appreciated the transparency, the honesty, and that the hospital did the right thing by getting all the charges for both set aside and taken care of. That was it. So when and I'm sorry, I didn't mean to digress, but when you have that discussion with the patient, by the way, you don't want to traipse in a big group of people, right? You're going to want the minimum number of people possible to make the disclosure fruitful. The reason for that is it's intimidating. It's intimidating to have a room full of people talking to you. And what you're trying to foster is a comfortable situation where the patient feels at ease in asking follow-up questions. So minimum number of people possible. And of course, you do want to do what the doctor in my scenario I just gave you did. You do want to pick up the phone and contact risk management, which is part of the legal department here at Erlanger. And you want to let the risk management director know, hey, this happened, I disclosed it, and yes, I documented my disclosure. You want to let them know that, just so that in the event something does come up down the road, they already know, hey, I know this was disclosed. Let's go back and look at this charting. And it just puts everybody, it's better to have advance notice rather than talking about things after the fact. And of course, by the Erlanger's policy, tape recording of the meeting is not permitted. Next slide. So we've already kind of talked about this, but of course this slide just talks about how we're going to stick to the facts of the event and what's known at that time, and don't speculate about what you might find out later or who was involved. You just push all that aside, just the facts and what we're going to do for ongoing care and treatment. Next slide. One thing that they are likely going to want to know, not everybody, but a lot of people, they'll ask, well, what are you going to do about this to prevent it in the future? And so frequently when I've had conversations, and mine are always way after the fact with patients, but what you'll want to let them know as well, if you're the disclosing physician or part of a team that's disclosing, you're going to want to give an overview of, hey, we're going to put this into our incident reporting system. It is going to be investigated. It's going to be reviewed and analyzed by the proper folks with the expertise in the particular area involved. And then there can be future meetings set up in after that's happened so that we can give you additional feedback. Because again, they're going to want to know, what are you going to do to prevent this from happening to someone else? And that investigation process is key to quality improvement. Next slide. So once you've gone through once that event has worked its way through, and Dr. Kohrt's going to talk about that again in a moment, but that investigative process through eSafe, for instance, I'll give you an example. If you have, let's say, a surgical error or a wrong site surgery, that would be entered into eSafe as an incident, and that would be routed to peer review. Medical Quality Improvement Committee will review that. And in that process, you're looking for people who have expertise in the area to review, to see, okay, what can we do from a process standpoint to prevent this from happening again, right? So there will be analysis of any event that happens, even if it's a visitor slip and fall and some water left on the floor. And then after that, After that quality review, there will be most likely more additional facts that you can, some of which you can share back with the patient. Okay, next slide.
As Heather just stated, this just goes again, and we've walked through this slide before, but basically, this is what happens. The information is analyzed, but I also felt that it was important for you as residents to know, and let's go to the next slide, that what happens is there's a referral that comes out of there, that report. That referral will go to your program director, who will sit down with you and talk about what happened. Now, the UT College of Medicine GME office is also notified about any time a resident is involved. Does that mean you shouldn't be reporting cases? Absolutely not. You should be reporting anytime you see a medical error or you see a practice or policy that you think is harming patients. That still should come to us. Now, that referral sometimes, as Heather just talked about, does go down to the medical staff. And if it's involved with behavior of a physician, it will go to the officers' council. If, and again, hopefully it never happens to you, but if it would, know that your program director will always go with you if you are ever called to the officers' council. The other place that it goes is the Medical Quality Improvement Committee. Those committees are actually in the process of being reformatted, but basically the Medical Quality Improvement Committees look at the behavior of attending physicians. They will look at the behavior of residents, but it's always within the context of the attending physician.
So we've had our analysis now. The event has worked its way through the eSafe analysis process. And now we probably know a little bit more about why the event occurred in the first place. Was there a breakdown in the process? Was the timeout procedure not handled appropriately? How was the wrong, did we not mark the right appendage? How did that happen? So now there'll be a discussion with the legal and risk department on how much more information we want to provide. Okay. And so often at that point, particularly if you've got a great relationship between the doctor and the patient, again, it's probably still good for that doctor to reach back out and talk to the patient about it but to let them know. But I would suggest that before it gets to that final conversation, that you do reach out to the risk management department for some advice around that discussion. Next slide. And of course, at this point, we're going to continue to provide emotional support to the patient, reinforce that we were right in the initial discussion, if that's actually true. Yes, in fact, here was the breakdown. Or if we were wrong about something in the initial disclosure about how something occurred, then we can correct it at this point, because now it's post-analysis, and provide any additional facts that are available. And then again, you want to go back to an expression of sympathy, whatever form that takes, an expression of regret. When you apologize, I want to say something about apology. There's a whole, if you type in medical error and apology, you'll find a list of white papers a mile long and a whole lot of research on it, and state laws that have been put into place to help protect physicians. All of that to say this. When you're saying, I'm sorry that something happened, there may not even be a medical error that caused it, right? I mean, very often there are known potential side effects of medication, of procedures, etc., that happen even when there is no medical error, right? And so you can be sorry that something happened without saying, I'm sorry, it's my fault. So I don't look at an apology as an admission of fault. but an expression that I'm sorry that this happened to you. Doesn't matter if anybody caused it, I'm still sorry that this happened to you. So when, again, as we talked about it earlier, often at this point, the patient's going to want to know, particularly post-analysis, what are you as an institution doing to prevent this from happening to someone else, to prevent this wrong site surgery from happening again? And you can talk about, here's what we've done. We've changed part of our process, X, Y, and Z to reduce the likelihood of this happening again. That sense of the greater good and that they went through something that actually made things better for others, people crave that. They crave to know that their suffering or the bad thing that happened to them was not in vain, but that the process, the healthcare system as a whole changed for the better because of it. That does make people feel better. And again, we're always, in all of these discussions, we're avoiding speculation, giving our opinions, or blaming other people. And then on documentation, and I'm going to talk about blame here for one moment. One of my least favorite documentation entries that I read, and I'm going to be vague around this, intentionally vague, was where a physician was very concerned about liability. It was clear. And so the physician documented about another service line in the health system and how that service line didn't do what they were supposed to do, and documented that. And so, you don't want to do that. You don't want to do that. If someone is prone to litigation, if they're going to go and litigate something, they don't need you to put it up on the tee, put the golf ball on the tee for them, right? Lawyers are perfectly capable, or we hope some of them aren't actually capable, of putting together a chronological timeline and figuring out what happened and doing discovery and figuring it out. So you don't document blame in the medical record. Now, when you're talking about, hey, I really think this service line should have done X, Y, and Z, would have helped the process and reduced the likelihood that this occurred, you can put that in eSafe. That's the place to put it, in fact. But it's not necessary for clinical documentation. At the end of the day, that medical chart is about the patient, not about you or anybody trying to practice defensive, blame. None of that. It's about the patient. So if what you're charting isn't necessary for their care, you've got to question, why am I putting this in here? But essentially, anytime you have a disclosure conversation, you do want to document that. You want to document who was present. You want to document, and of course now with Epic, you're going to have everything's automatically time-stamped, but you're going to want to put in what time the conversation occurred and where you were. You want those details around it. So from a legal standpoint, the reason I like to see that documentation is sometimes there's a question about when the statute of limitations in a malpractice case starts to run. But if we have a clearly documented disclosure discussion, then the patient can't later come back and claim, well, I didn't know about it at that point. I didn't find out until 2 years later when I go to this other doctor who says, hey, this doctor did X, Y, and Z. We want to avoid that. Well, if we have clear documentation around the disclosure and who was present, what was disclosed, only the facts, and the date of that, you're good. That's good documentation. And then you're also going to want to show that you talked to the patient about the medically significant facts disclosed and then any changes in treatment that were discussed, or that they didn't need any treatment changes, that everything was fine. Next slide. And of course, an event, if you get to the point where you're having to disclose something, you might want to think about picking up the phone and calling risk management. And if it's something that's significant enough, you could also call the insurance carrier, which for residents right now, that's a little bit different. You guys can speak to that. For our physicians here at Erlanger, they have an insurance carrier. And so sometimes we would want to go ahead and call them and put them on notice. Again, if you're in doubt and you have questions, you would want to reach out to the risk management department for guidance around that. We're here, we're able to help. We love to be proactive rather than reactive. So anytime you want to call, please feel free. And second, victim support. Dr. Kohrt, I don't know what UTCOM's setup is for that.
Well, I'll go over that, but I think basically, thanks, Heather, that was fantastic.
You're welcome.
in the past, we've given this talk and we have not talked about second victims. And I think with the focus on wellness and with the focus on mental health for residents and attendings, it's extremely important to say, if you've gone through an event where there's been an unanticipated outcome, where there's been an adverse patient event, a medical error, there are a lot of feelings that get generated, and we can't just ignore those. So if you have an event and you're feeling depressed, upset, whatever, know that we have services. There are services both through Erlanger Health System for faculty and employed physicians, but there are also services for residents. You can get counseling. Next slide. You can get counseling through NextGen EAP, and all you have to do is talk with your program director, or you can even call over to the UT College of Medicine and talk with Pam Scott, and we will get you set up with NextGen EAP, which will do short-term counseling for you, and also will provide long-term counseling, but that's a little bit different, but short-term counseling for this specific incident. I think we all in the past have always felt like, well, I'm tough, I don't have to talk about that, or we shove it over to the side of our brain where we don't have to deal with it. But it does have an effect, and it will be an event you'll remember for the rest of your life. So if you are depressed, if you're feeling very upset about it, I think, do the right thing. Go ahead and give us a call, contact NextGen. The other place you can contact is LifeBridge, which is through the Chattanooga Medical Society, and they also have access to a counselor. So again, just remember, these are hard events. They will have an effect on you, and if you need to talk about it or discuss it further, please feel free to give us a call. And with that, I think we are ready for any questions that you all may have. You can go through the chat or you can raise your hand. Kim, I'm not seeing any questions.
I'm not seeing any yet either. I would.
Okay, well, with that, we have had 73 people sign in. And we thank you all for your participation. I want to thank Heather. She just did a terrific job. She's pulled this all together. We do have this new guideline now on disclosure. And in fact, some of the changes that Heather highlighted, especially the fact that in the past it has not been required for you to tell a family if an event reached them but didn't cause any harm, you were given the choice of whether you told the family or not. With this new guideline, you are required to tell the family if the event reaches the patient, even if it doesn't cause any harm. And some of your attendings may not even be aware of that change in policy. We're going to have to make sure we do an educational effort to let other people know. But with that, Heather, any other final comments?
No, thank you all for bearing with us over the last hour. We appreciate it. And if you think of any questions later, please feel free to email me. And if I don't know the answer, I'll find someone who does.
Again, thank you very much, and enjoy the rest of your day and stay safe.
Thank you.
Thank you, Heather and Dr. Kohrt. Bye-bye.
Bye.